However, I'm going to pivot for a minute so that we have a chance to hear from Janet. So Janet Meyer is one of my colleagues. When I was with Health Management Associates, I had the pleasure of working with her there, and was really integrally involved as a leader in moving health share of Oregon, which is for them, they call it Medicaid, right? Like the rest of the country. So Medicaid, managed care organization is what they call it there in Oregon, right? Moving them toward the really successful integration of what they call traditional health workers. So I'm going to pass this over to Janet, who will provide a little bit more introduction on her background, so she can say it in her own words, and then talk a little bit about what we're going to do next. And I think you're here, Janet, but I have lost some of my view, so I'm just going to hope I can see you.
Good morning. I'm here.
Yes, great.
Hi.
Perfect. There you are.
Thanks for having me. I'm excited to share a slightly different approach to incorporating community health workers in managed care, but I hope you'll find it intriguing, or at least planting some seeds of different kinds of approaches and ideas you might want to take. So in the next 10 minutes, I'm going to tell you about Oregon's Medicaid managed care model and how CHWs fit and are required to fit in our model, and then how health responded. A little bit about me. I was the founding CEO of leading the organization for 6 years after launched, and it's the largest coordinated care organization in the state, third of the Medicaid enrollees in that CCO, as we call them, and it's the greater Portland metropolitan area is the service area. I have about 18 years experience in managed Medicaid and about a little over 30 years experience in managed care. I discovered Medicaid about 18 years ago and fell in love and haven't been able to leave. So, but I enjoyed the challenge of launching and seeing CCOs get going up in Oregon, and I hope you'll learn a little something about that. Next slide, Shannon. Real quickly, Oregon's coordinated care organization started in 2012. Our model is to put all populations and all benefits in a global budget and give it to the coordinated care organization. And by all populations, that includes affordable ACA expansion population, CHIP, the categorically eligible Medicaid clients, dual eligibles are passively enrolled in Medicaid in Oregon and managed Medicaid, foster kids in foster care. So there's really no population that's carved out of managed care in Oregon. And again, it's all in one program, except for American Indian and Alaskan Natives. And then it's all benefits are in one plan, which gives us a lot more flexibility than some of the Medicaid models in other states. So it's not just physical health and pharmacy, it's mental health, including people with serious and persistent mental illness. Transportation is included in the Oregon Medicaid model for managed care, and dental. So it's all benefits, all populations. 2012 launch of those introduced managed care. It says my internet connection is unstable. Can you hear me? Okay. So in 2012,
you're going in and out just a little bit, Janet. So we might do to salvage this is as much as I want to see your face, you might turn the video off, and then that will give your audio a better boost.
I've seen enough of my face in the last 10 months. So, we were introduced to screening for social determinants of health. It was a requirement that was put into our 2012 contracts. Community investment became required as part of our responsibilities as tax-funded entities. And in lieu of services were also incorporated back in 2012. We call flexible benefits or health-related services, but they're basically in lieu of services. So we started on this SDOH and in lieu of services 2012. And then we were required to include CHWs in some way, shape, or form in our transformation plans. So the first thing they did was establish a traditional health worker commission. It was established by legislation. Their job was to adopt by rule education and training requirements. The only stipulation to that legislation was that whatever they did had to meet FFP requirements for federal financial participation And it had to be broad enough to not to maximize the managed care plan's options. So they couldn't, tie us into one model that, one size fits all. So we do have from that Traditional Health Worker Commission, which is still in effect and it's still operating, we do have certification and payment guidance now from that effort. So we have standardized education and a certification program. There's guidance that the state has issued on fee-for-service model, but provide us with that guidance. And if we pay for counterable services, we can manually include the costs when we reconcile for our minimum MLR calculations and for rate setting purposes. So even though we can't encounter a lot of this work, we can still include it for rate setting and for minimum MLR. CCOs are not told how to do this. It's just go forth and do good work is sort of the message from our state agency. So we do have the flexibility to do what we think is right for our community and our network and our delivery system. The state has, very much emphasized that CHWs are effective bridges between their communities, social services, and the healthcare system, which I've heard from you guys. I mean, this is not news to us. The challenge is the how, right? How do we do this? So next slide. The first thing HealthShare did was to sit down and say, okay, well, what's the best strategy for really supporting this model of care? And we went through and we sort of was the pitfalls of programs. Turnover. There's a lot of instability in this workforce, and that is costly. It's costly for the payers. It's costly for the clients. So how could we design a program that would try to ameliorate some of that staff turnover? There's no infrastructure out there to support these workers. Appropriate supervision and job security is important. So having that infrastructure that's relevant to a CHW is important. Often CHWs have been disease-centric and clinically focused for a population with high social needs. So how do we balance that? We have obligations in disease management and clinical operations, but we also recognize that our population has high social needs. So how do we address those? We really talked a lot about that CHWs are either disconnected from the healthcare system or they're too embedded in the healthcare system. And both arguments were made to us that the only way they can be effective is to attach them to a primary care clinic, or that if you attach them to a primary care clinic, you're really, making them less effective in their own communities. And then, I had a board, and the board wanted to know what the evidence was in improving health outcomes and what was our evidence-based measurement. And that's really challenging because of data collection and analysis limitations. So the question we had is, how can we best support this workforce? Many of our partners, and we did a lot of sub-capitation at HealthShare, many of our partners were paying for CHWs through PMPM payments to primary care. So incentivizing primary care practices to use CHWs as part of care management extenders. And most of the CHW activity was attached to those PMP payments at the primary care clinics. Some of the CCOs across the state were hiring CHWs to work for them and then deploying them in outreach programs from the managed care plan. And those were probably the two most common models. HealthShare really wanted to think through, and in our market and in Greater Portland, what the right model looked like for our community. So we're not Eastern Oregon, we're not Southern Oregon. We had a multi-system integrated delivery systems all competing with each other. It's a typical metropolitan healthcare system and environment. So we really wanted to figure out what could we do as an investment for this process. Next slide. So I'm going to propose to you a different kind of idea about CHWs that takes them outside of the medical system and puts them in a community-based and culturally specific model. And I encourage you to think about CHWs in your region as part of a public utility, if you will, so that we have 55 different, electric companies or gas companies. We have the community draws. If you really think about organizing the CHW workforce as a public utility that can be accessed by managed care, can be accessed by hospitals, by CBOs who want to hire them, by physician offices. And, to me, the public utility approach shares the cost of this workforce across many payers. And even though you all know what the wrong pocket problem is, right? That's where you make the investment and the return on the investment goes to somebody else, right? It doesn't come back to your pocket. But approaching community health workers as a utility for the community to draw on helps to ameliorate that wrong pocket problem a little bit. So if you think about investing in infrastructure as part of your community benefit investments, this requires you to get your hospitals to invest with you in a community benefit initiative and to think about how we're going to build out this resource for our community, for our population. You want to require data and reporting capabilities from the organization and supervisory and continuing education programs. The CHWs need to have supervision from people who do the CHW work. You just can't have a nurse case manager supervising CHWs effectively. There's a disconnect there. So really providing a place for CHWs to come together and be CHWs, be supervised and evaluated by their peers is a very effective way to support that workforce and to hopefully lower the turnover. So community-based, we went with a community-based approach because at the end of the day, members have close and trusting relationship with social service agencies, not insurance companies or even their PCP. I mean, I think that's pretty obvious. Most of our clients, our Medicaid enrollees, spend more time with social service agencies than they do with us. So why aren't we getting out to them through the social service agencies and help the CHW resource? So it strengthens the social service agency. And again, it uses this hub and spoke model, if you will. The public utility idea may not sell, but a hub and spoke model might make more sense to you. So how do you support the hub so that the spokes are where we need them to be? And then culturally specific is obviously very important. I like to think about, we had an agency doing culturally specific CHW work with a Middle Eastern population, but very low developmental screening rates in that population. And we were trying to figure out how to get through and be more effective. And it turned out that they believed that those developmental screenings were a way for the government to take their children away. And so by having a culturally specific community health worker work with that work with those families one-on-one and build that trust, we were able to get the developmental screenings. And that health worker also was able to help that family navigate the system if there were findings on the developmental screen. So that's just a small example. I'd like to think MCOs can create programs that maximize impact. If you roll up your sleeves, take a risk, and partner with your community, partner with your health systems and other large CBOs. I'll go really fast, Shannon. I know I'm out of time, but the last slide's important. When you talk about paying to maintain capacity for this workforce, how do you pay to maintain the hub of CHWs? Establishing metrics and letting them advance and adapt over time is very helpful. Finding baselines to start with, member engagement, completion of referrals, et cetera, et cetera. Per member per month payments provide build teams, the right skills and experience. Case rates are really hard to calculate, but they can work well. We used case rates for the homeless population community, and the case rate is going to shock you. It was $4,500 per member to get these clients into services. These were primarily clients who were loyal customers of the 911 system. So we were trying to address their use of 911 through this outreach program. And a lot of these case rates were high because about half the time was spent searching for the client. And about another third of the time was spent trying to keep the client in services. So there's a lot of non-productive work that goes on in this, but it turned out it gave us a 3-to-1 return on the investment. So the case rate was worth it. And then I'll just let you read the rest. But just to remind you in closing that these CBOs that employ community health workers and deploy community health workers are really fragile. I often say, I don't know how they make payroll half the time. They're just economically very fragile. And they're culturally different from managed care. And so we need to approach it with that in mind, and that patience in contract negotiations and investments need to really be structured so that you don't destabilize that really important safety net. That's it, Shannon. I know I went over. I apologize.